an ENT surgeon, a maxillofacial surgeon who has an interest in temporomandibular joint dysfunction, an anaesthetist with an interest in pain, and a psychiatrist. And it's the latter two that are the most important within that clinic. We've all had patients who come to us saying, doctor, I've tried everything and I need an operation. And a facial pain clinic sometimes makes the doctor feel like that. Facial pain is a common symptom in our clinics, and the sinuses lay just behind the location of where the pain is, and so it can be termed as sinus pain, and patients then understandably will associate their facial pain, their headache, if it's in front of a sinus, with sinusitis. And then this is propagated by other primary care and sometimes secondary care doctors as well. But I'd like to put it to you that pain secondary to sinusitis is not common. What is pain? Well, it's subjective, it's not objective. There's no test that I can do that will determine whether someone's pain is more than somebody else's pain. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. There is a sensory nociceptive component, but there's a significant affective component, which is the patient's feelings about the pain, and anxiety, depression play a big part. There's an interpretive, an evaluative, cognitive component, which is about the patient's beliefs and attitudes and expectations. So what factors are relevant in chronic pain? Well, Professor Kashkai has already mentioned odontogenic pain, and it's crucial that you always have that at the forefront. So other predisposing factors, there is a genetic component. Childhood trauma plays a part, anxiety, depression, and then associated pain syndromes. So if you've got someone with other associated pain syndromes with facial pain, you need to step back. This is not sinogenic. You want to think about precipitating factors, life events, physical trauma, whether that be trauma in the manner of previous sinus surgery, and then perpetuating factors. Think about their own beliefs about the pain, and then unhelpful behaviours. Do they have a cancer phobia? Go through in your history about the previous treatments that they've had. Over-investigation can further deepen a patient's misbelief about their pains, and we've got to be careful about not only over-investigation but over-treatment. And within these multidisciplinary clinics, we will often see patients that have had many teeth that have been extracted, many endoscopic sinus operations, and then to come round to the understanding that there is not an organic cause for their pain. It's important, though, that we do take patients seriously. We take a detailed history, and we are there ruling out any other causes that may be there, but knowing that over-investigation does have a significant economic burden. So arriving at the correct diagnosis requires a detailed history, but also a knowledge of the common diagnostic categories. And what we don't know, we will never find. So I'm going to put to you some data from a study that's now over 10 years old, but is still very relevant. And it was something that I was involved in my fellowship in Nottingham when I was with Professor Sama and Prof Jones. And we looked at 973 consecutive patients in a rhinology clinic. And it was a prospective study. we, in those 973, we looked at symptoms of facial pain, and there were 409 patients. Of those 409 patients who have come to this rhinology clinic, we then followed them up for an average of 2 years and 2 months. And at the end of that period, we went back and we classified those 409 into these categories of facial pain. And what I'm going to do is to go through some of these categories so that we can then understand when we meet our patients in our clinics, try and put them into some of these diagnostic categories. So when I do see a patient, I always ask them, where is the pain? Does it radiate anywhere? Does it radiate down the neck, down the jaw, over the temporal regions? I want to know, is it continuous or is it intermittent? I want to know about the character of the pain. Is there a burning pain, a deep pain, a superficial pain? Are there any precipitating or associated factors that go with the pain? Is there an aura? Are there any relieving factors? What's the patient done that helps? Do they have to go and lie down, switch the lights off? What effect does the pain have? Does it really stop them doing anything, or do they take a lot of time off work? Find out about their social circumstances. Everyone gets an endoscopy. Endoscopy in clinic has a high sensitivity and a high specificity. I consider imaging in patients where there is something that is atypical and I want to rule out another cause of their pain. But you've got to remember, if you image someone, then up to a third of patients will have mucosal changes in the community. And that doesn't mean that their mucosal changes are a cause of their pain. If they have a history of bacterial sinus infections with fever occurring more than twice a year, then I think about immune testing. If we look at this picture endoscopic view, we can see that there's a contact point. So this is the nasal septum with a spur and the inferior turbinate. In the literature, there is a term that's Schluter's neuralgia. And this was from 1908 when Schluter described a symptom complex consisting of neuralgia with sensory and gustatory manifestations. And he believed that this contact point resulted in these symptoms. And it was in 1942 when McCullough tested this theory by applying various nociceptive stimulants in the nose and coined the term Schluter's neuralgia. All these tests that were done in the 1940s were repeated in 2000, and categorically this doesn't exist. So don't operate for a contact point, or if you do, you've got to be really, really careful. So let's get back to these 409 patients and the causes of facial pain. So the most common in this cohort was midfacial segment pain, just over a quarter. So this is a symmetrical sensation of pressure, and it's often a heaviness or a pressure or a tightness in the midface. Some patients will feel that their nose is blocked. However, when you ask them, can you move air? They can move air. So there is no actual airway obstruction. It involves areas of the midface. It's usually symmetrical, and they will describe in about 40% concomitant symptoms of tension-type headache. They may have an area of hyperesthesia of the skin, of the soft tissues of the midface, which gives them a feeling of puffiness and swelling, although there isn't any objective evidence of that. Nasal endoscopy is normal, and if you do undertake any imaging, then it's normal, but note that in a third of normal patients, CT scans will have incidental mucosal changes. There's no consistent exacerbating or relieving factors, and the symptoms can be intermittent or chronic, and they're often there for years. How do you manage it? The diagnosis is on the history. Low-dose amitriptyline, and we usually start at 10 milligrams taken at night, and then increase the dose by 10 milligrams after about 6 weeks. And the majority of patients will find benefit. I will usually treat them for about 6 months and then they stop. They get an information leaflet about amitriptyline and the side effects, the most common being drowsiness, constipation, and dry mouth. If they are sensitive, and a small number of patients will have significant drowsiness, then a second line is duloxetine, and duloxetine is also very effective, but not as effective as amitriptyline. It's a serotonin norepinephrine reuptake inhibitor, and I'd start at 30 milligrams and after 2 weeks increase to 60 milligrams a day. So sinogenic pain, so this is what we're talking about, so what proportion of patients with facial pain is it sinogenic? It's just under a fifth. It usually follows an upper respiratory tract infection. It's got typical unilateral features with pyrexia, unilateral obstruction, and nasal discharge, and endoscopy shows pus in the nose, and one would treat them as one would for an acute sinus infection with nasal decongestants and appropriate antibiotics. Chronic sinusitis typically is painless. Pain will occur if there's a secondary sinus obstruction and a secondary acute exacerbation. And again, one would treat it as for an acute infection. Tension type headache is in our group was 16%, and almost all patients with this present with typical symptoms with symmetrical, usually frontal headaches that will radiate around the sides, a dull feeling of pressure, tightness, and it can be chronic or episodic. And again, the history is quite typical. Think about the precipitating factors and then treat as one would for a tension type headache. Low dose amitriptyline also works very well for this. Facial migraine, so 13% of the cohort had a facial migraine. This can be either a classic type or the common variant. The classic type has all the usual hallmarks. It's easier to recognize because there is nausea, there's an aura and photopsia. Photopsia is flashing lights, and it responds very well to aspirin if given early, or one of the triptans like sumatriptan. So I would usually give patients one treatment of sumatriptan, which comes with 6 tablets, and I tell them if it works 4 out of 6 times, it's the right diagnosis, but you've got to take it early within the first half an hour of the pain coming on. The common variant of this doesn't have the nausea, but has the other symptoms, and the treatment's the same. So atypical facial pain, this is a much deeper, ill-defined pain. It crosses dermatomes, so it's not in the classic distribution as one would for a dermatome. There's no organic cause. It's usually unilateral, more common in women over the age of 40, and it can move. It can alter location. It can be on one side and then cross over to the contralateral side. Psychological factors play a major role, and with atypical facial pain, one can again start with low doses of amitriptyline, but in these patients, I get them to increase the dose every 2 weeks by 10 milligrams, reaching 100 or even 150 milligrams. Or one can move to other drugs such as gabapentin. Trigeminal neuralgia, this is a deep, agonizing, lancinating pain. This is in specific trigeminal divisions of the maxillary mandibular divisions. There may be a trigger point, and again, it occurs more commonly in women over the age of 40 and responds to the usual things that we treat trigeminal neuralgia with. So moving on to the less common things, so cluster headaches and paroxysmal hemicrania. We'll start with cluster headaches. So these are characterized by recurrent unilateral attacks that are really severe. They can last up to an hour, and cluster headaches occur in men between 30 and 50. There's associated unilateral flushing, unilateral nasal obstruction, and watery rhinorrhea. There can be periods of remission for many months in between, and cluster headaches respond very well to triptans and pizotofen. Paroxysmal hemicrania is similar unilateral severe pain, but this time it's in women. It's usually in the frontotemporal regions, lasting between 2 and 45 minutes. There can be frequent attacks, 5 a day, with marked autonomic features again. These respond very well to high doses of indomethacin, and that's important and crucial in the diagnosis as well. Myofacial pain. So 3% of this cohort had myofacial pain, and this is more common in postmenopausal women. Strong association with stress and features crossing over with temporomandibular joint dysfunction. It's poorly defined, with pain radiating down to the neck and the jaw, with tender points around major muscle groups. Tricyclic antidepressants help. In our clinic, we've started, our maxillofacial surgeon has started to inject botulinum toxin with good success. So our clinic has a multidisciplinary role. The key people actually, I think, are the physicians in this, the anaesthetist, the psychiatrist. What do we do in the clinic? We look at the drugs that they're on. Occasionally, we do consider surgery, whether that's ablation for pain, so the infraorbital nerve. We've got a physiotherapist, and we talk about coping strategies. We've got our psychiatrist who delivers cognitive behavioral therapy, but it's multidisciplinary, and it's making sure that we try and give the patients the tools to try and cope and to manage their pain. So take-home points: facial pain is common. 81% of patients with facial pain coming to our rhinology clinic, it was not sinogenic. The diagnosis will take time in your clinic, and that's something that is very precious and we don't have. But if you do take the time and you go through your surgical sieve and you understand the common groups of pain, then it's easier to get to the diagnosis. Patients will often come to your clinic having seen many different primary and secondary care doctors, so they're frustrated and distressed, and they need a lot of listening to. Everything I've said was published in the ENT Masterclass journal, and I'm grateful to my mentors. Thank you very much.